for them as well, but that's sometimes hard to do when you're sharing the screen. So I thought today we would talk about suicidality and not necessarily suicide risk assessments. I know many of you work in the CED, you're clinical social workers at Sharp Hospital. Suicide risk assessments, I think, are something you're probably already familiar with. And so I thought we'd focus today on our kind of preliminary understanding of suicide risk and the COVID-19 pandemic. If people have questions about suicide risk assessments, I can do my best to answer those as well, as this is a new topic and still an ongoing current event with the COVID-19 pandemic. This is a first time through this presentation, so please stop me if you have any questions or things aren't clear. Also, please share any anecdotes you might have, any research that you've read about. This was kind of a preliminary first look at the literature, but definitely not exhaustive. So let's do a quick outline of what we're going to talk about today. I just want to start with a general overview of suicidality, some US-based and West Virginia-based statistics. Throughout this presentation, I try to focus on psychological impact and suicidality of the COVID-19 pandemic within the United States. And I chose that because I think the United States response to the pandemic has been different than other countries. And so I didn't want to confuse what might be happening with our population here in the US with what was going on in other places when they have responded differently and may be seeing different amounts of numbers of COVID cases. So we'll start with that general overview of suicidality. We will then talk about the history of suicidality and other pandemics. What can we take from previous pandemics and health issues that have gone on in the world. Also, we're going to talk about our early in the pandemic understanding of the psychological impact. We're going to look at that in the general population and in healthcare professionals, as all of us are healthcare professionals and are working closely with other healthcare professionals. And we should be thinking about how we're supporting our patients as well as our colleagues and coworkers. We'll look at how COVID-19 specifically is going to could impact suicidality. We'll look at risk and protective factors of suicidality, specifically looking at how COVID could help that, how that could impact in a positive or negative way. And then lastly, I've got one short slide about suicidality, COVID-19, and rural communities, since that is where we are working. Most of our population is living in rural America. Okay. Quick, super fast overview of suicide by numbers. You will get a PowerPoint with all my slides and my notes. It has links to where this data all comes from. The most recent data we have is 2018, so a little bit old. But in 2018, there were 48,000 completed suicides, which averaged to 132 a day. That is one person every 11.9 minutes. This at that time was the 10th ranking cause of death in the US and the second leading cause of death for adolescents and young adults ages 15 to 24. There are 3.65 male deaths by suicide for each female death. Anybody want to speculate as to why males have a higher rate of death, but not necessarily a higher rate of suicide attempts?
Isn't it usually because they use more lethal methods?
Yes, that's exactly it. There's more gun deaths when it comes to men than women, and women tend to choose different means such as overdosing, which may or may not be lethal. Thanks, Mariah. And in 2018, there were 1.4 million suicide attempts. And if we think of many of those suicide attempts resulting in at least an emergency department visit, if not inpatient hospitalizations for a brief stay, it reminds us of the extreme impact financially of suicide attempts on our nation and our healthcare system. Specifically for West Virginia, this comes from the American Foundation for Suicide Prevention. 2019 numbers, although they said it's also kind of 2017 data from the CDC. Like in the whole US, suicide is the 10th leading cause of death in West Virginia, but it's second leading cause of death for those ages 15 to 34, fourth leading cause of death for those 35 to 54, and as you can see, 8th and 16th leading cause of death based on other age groups. Interesting statistic that they noted here is that more than 5 times as many people died by suicide in West Virginia in 2017 than in alcohol-related motor vehicle accidents. And what seems to make politicians and the higher up administrations really take a hard look at things is the cost of suicide and mental health in general. It says here that the suicide cost in West Virginia totals $307 million in lifetime medical or work costs in 2010, or an average of over $1 million per suicide death. Questions on these statistics? I think we're all starting to get used to the COVID silence and break that or Zoom break that we have to have. All right, I don't see anybody having questions. So let's look specifically at the impact of COVID-19 on psychological distress and suicidality. I'm discussing psychological distress as kind of an introduction into suicidality, kind of on a continuum of, people could have minor psychological distress all the way to more major psychological distress, which in some portion of the population could lead to suicidality and or suicide attempts. Some caveats to the rest of this presentation. It's this understanding that research takes a lot of time. Studies can take years from the idea phase through the conducting of the study phase and then through the manuscript phase and peer review. And that, for the purpose of this presentation today, that means that some things we may be talking about have actually happened years ago. What's also important to keep in mind is that research on COVID has been moving at lightning speed. We have studies that are conducted in March and were published in June, which is unheard of in at least the psychology literature. But that also means that as research is being pushed out very quickly and going through peer review very quickly, it's also becoming outdated very quickly. So you'll notice on some of the upcoming slides, I have put a citation, and then in brackets, I have put a date. And this means this is when that study was published. And it's just trying to give you an understanding of the context of where we were in the pandemic. Because I imagine that each of us could think back to, say, St. Patrick's Day. That's kind of my marker of when COVID really took off and started to affect our lives in the US. So thinking about how you felt and what things were going on in March versus June versus August versus now puts us all in very different places. And so I think that that time is important to consider when we're talking about what kind of information we have gathered and what we know about psychological distress and suicidality at that point in time. It's also important to keep in mind that some of this research is, and some of this understanding of how suicide was affected by the COVID pandemic is going to take months. Some researchers speculate it could take us 18 months to really understand the impact of suicidality and COVID-19. And I would speculate that it may be 18 months after we have the virus under control, because at this point, I'm not sure we're still at a point where we can say that things are moving in a different direction and we can look at this like COVID time, because we're still kind of in that COVID time. Also, I want each of you to think about this project today as a preliminary kind of living review of the literature. All of this research is changing as we speak, and there are many forces that are going to come into play with how it could all play out in the future. So we'll talk about some predictions people are making about suicidality and psychological distress, and we'll talk about how that could be affected positively or negatively by decisions made at all different levels, local levels, state levels, and federal levels as well. Let's talk historically. It's important for us to sometimes look back in the past and see what has happened then to help us predict what might happen in the future and maybe to prevent it if possible. So what we know is that historically, everyone has been talking about the Spanish flu of 1918, 1919 as the closest thing we have in the US to the size of the current pandemic. So the Spanish flu infected 500 million people worldwide, and 50 million people have died. 675,000 of them were in the US. The last numbers I read on COVID, and please correct me if anybody has more recent or better statistics on it, I believe that 8 million people have been infected with COVID. That may just be a US number. And I know in the US, over 200,000 Americans have died. So we're not quite as bad as the Spanish flu was at this point in time. What we also know about the Spanish flu is that there were increased rates of suicide at this time. And researchers since then believe that what led to the increased rates of suicide were decreases in social integration and interaction and fears about the pandemic. And you'll see as we move forward that when we talk about how to predict what's going to happen with the COVID-19 pandemic, that these same ideas are going to come up again. A more recent one, but not US based, was the SARS outbreak. This one's important because the SARS virus is very similar to the COVID virus, but it didn't affect the US. So the SARS outbreak in 2003, they did see also saw increased rates of suicide. And what they found is that the individuals who were attempting and completing suicide had fears of contracting the illness, fears of being a burden on family members. They had general anxieties, they had feelings of social isolation, and they had psychological distress. And so this is just kind of the history behind other pandemics. We will also talk about other aspects related to suicidality, particularly financial aspects. So we'll look back to the housing crisis of 2008 to see what had happened with suicide then as well. So what do we know at this point? And so I want to direct you down to that citation at the bottom. This was a study published in June, the end of June. And so when they're talking about data of early psychological impact, they're really talking about China, who had experienced and kind of dealt with the shutdowns and lockdowns first, end of January, beginning of February. And I believe most of these studies took place in China. And then when we're talking about the US, we're really talking about March. There isn't a ton after that at this point, when all those studies are coming out. So in China, what researchers found was increases in anxiety, depression, harmful alcohol use, and decreases in mental well-being. And they actually found that it was younger people who were struggling with the mental distress of the pandemic, as far as it related in China, particularly individuals ages 21 to 40. They also surveyed frontline healthcare professionals and found that they had the highest risk of anxiety, depression, insomnia, and distress. And we're going to get into some of these psychological factors in just a second. But I want to point you particularly to insomnia, because we know that sleep disturbances are a huge risk factor when it comes to suicidality. And some interesting statistics from the US. Research found that alcohol sales rose 55% in the week ending March 21st, 2020 compared to the previous year. So I believe they surveyed March 13th to the 21st. And so if you guys can think back to that time, I think March 13th is when schools in Mon County, WVU, I think shut down like March 10th, or announced they were shutting down about March 10th. About the 13th, schools were starting to discuss shutting down. By St. Patrick's Day, we were pretty much all shut down and our lives had been disrupted. And then alcohol sales in that same time period online alcohol sales jumped 243%. So everybody had a level of probably uncertainty, some questioning, and we know at least alcohol sales rose, which begs the question of whether harmful alcohol use and our alcohol use disorder could play a role going forward. We also, research has found that there were an increased number of calls to suicide prevention hotlines in the early March time in the US. I'm going to pause here to see if anybody has any comments. So I hope this slide is clear enough for everyone to see. This was a study, and I thought a great graphic that looked at relevant psychological reactions in the general population as it related to COVID infections. And so at the top, you see factors that are working on decreasing a person's subjective well-being. These are things like loneliness. There was a lot of people who became very isolated with the lockdowns and shutdowns. There was a specific or uncontrolled fear, kind of this worry about the uncertainty of how this virus spreads, how serious this virus is, and what's going to happen in the future. They found pervasive anxiety in the general population, and then also this kind of frustration and boredom. And we will talk about that frustration and boredom piece a little bit more later as how it may impact rates of psychological distress and suicidality later down the road, more so than this time period, which again was June. So you're thinking this was the end of March survey period. What I liked about this study is that they looked at risk and protective factors. So here on the right-hand side, we have things that, in addition to subjective well-being, make it more likely the person suffered from a psychiatric condition. So not just some anxiety, frustration, boredom, loneliness, but making its way to an anxiety disorder, a major depressive disorder. Things like inadequate supplies. How many people remember the toilet paper shortage of March 2020? But for some people, that also may include PPE, lack of supplies, inadequate information. We didn't know, the CDC didn't know. There was a lot of contradictory information coming out in the very beginning. I think people were well-meaning and trying to get information out, but it may have just been a bit confusing, or we didn't know enough at that time. And this alexithymic traits, this is an understanding of not having words for emotions. So if somebody doesn't have the ability to describe the emotions that they're feeling, that increases the likelihood that they may then have a psychiatric condition with their decrease in subjective well-being. But they also looked at positive and resiliency factors, the protective factors, including this like resiliency that people have, and the idea of like more social support. Those who felt more supported or were able to find a way to connect with loved ones seem to be able to make lifestyle changes and adapt to the environment. It seems like kids have done this really well, and I hope Amanda is here and maybe could speak to what she's seen in her clinics, or even the CED folks that we have here as you've been working with kids throughout this. But kids are really resilient, and they have made a ton of adaptations. I took my 4-year-old to vote this morning with me, and she wore her mask and she stood in that line, and she was fine. She didn't think twice about having to put her mask on and not put it below her nose the whole time we were in there, which has been something I think very difficult for adults to do. Amanda, you have any thoughts on kids and their adaptation with COVID?
Yeah, I think that kids, you're right, they're so resilient, and kids are really adapting to a lot of the different changes. I think there's still an underlying stress that that the kids are experiencing that sometimes they're not able to verbalize, just like what you're talking about with adults. And so helping coach parents on how to help them with that has been really helpful. But one of the things that parents always express to me about the mask wearing is that, especially for younger kids and in early childhood, about their concerns of language development and the impacts on development. And while there's an impact on development, there's a lot of research that supports that, you know, in the countries where they wear mask coverings, so due to their cultural beliefs, due to sandstorms, whatever it might be, that they wear those, that kids have adapted to development really well. It's taken 2 to 5 years, but that they've adapted to that.
Thanks, Amanda. That's wonderful news, and I'm sure soothes some anxieties in parents. CED folks, any thoughts on this and the kids that you've seen?
Yeah, I echo the notion that children have been surprisingly resilient with a lot of this, and even some of the individuals I work with who are maybe on some of the more stereotypical ends of the autism spectrum, who you would expect would have a lot of sensory issues with mask wearing. Even some of them have been very successful with returns to school, you know, that they'll wear masks during the times that they're congregating alongside other people. But there's a collaborative process of, say, giving them like a calming space, someplace they can go to where they can take that mask off, have, you know, extra distance with others, and then they can return to that once they're in closer proximity. So I've been very impressed by those particular adaptations.
Wonderful. Thanks for sharing, Nick. Any other thoughts? Let's switch gears. So this was kind of how the general population coped, or some thoughts on how they coped with COVID. Let's look instead to impacts on healthcare professionals. So what researchers found, they did find a high prevalence of anxiety and depressive symptoms among healthcare professionals, and they linked them to one of 5 areas. This one lists them out as 6. So we'll do 6 areas. First, we have COVID exposure. Then they looked at COVID exposure, epidemiology, health policies, material resources, human services, and personal factors. So these were all factors that related to more anxiety and depressive symptoms in healthcare professionals. So being the first line of care, emergency departments, primary care, COVID-specific units or COVID-specific hospitals, if they were COVID positive, they acquired the virus and had to quarantine. If there was peer infections, if peers had died, vicarious trauma, watching others struggle to breathe in their last moments and struggle to breathe alone without their family. If they themselves were hospitalized with COVID, helping people make end-of-life decisions. And this degree of responsibility is an important one when it comes to healthcare professionals. They found that the more responsibility a person had, the higher the anxiety and the higher risk of anxiety and depressive symptoms. There was a ER head of the emergency department in a New York City hospital, completed suicide, and people discussed this kind of feeling of feeling like they were helpless. Their job is to save people, and they just weren't able to save enough people. And so the more responsibility a person had in the healthcare environment, the more at risk they were, and still are. And then second line of clinical care, and those that were remote teleworking also affected how they felt. When they're talking about epidemiological issues, they said that this was kind of looking at from a population standpoint. And so when COVID cases are increasing in specific people's areas, that's when they're at higher risk for anxiety and depression. Kind of makes intuitive sense there. And so then they talk about this pandemic stage. You know, we've heard things about waves, first waves, second waves, third waves. I don't know if we're in a wave, if we've had a wave. That it doesn't seem like it's ever really come down. And I think understanding pandemics and understanding had they helped with Ebola in the past, or another pandemic, and they had some kind of understanding of how this is going to go, what it's going to look like. A lot of these mental health symptoms come from this level of uncertainty or lack of understanding that we have about what we're about to face. Then they talk about health policies, governmental action, public health strategies, the public health system's coverage, data transparency. All of those increased healthcare professionals' anxiety and depression. Material resources, we heard this a lot in the beginning. I think things seem to have gotten a little bit better, maybe partly because we understand what types of personal protective equipment is necessary and what isn't. But in the beginning, when people were wearing trash bags because we didn't have enough gowns, I remember hearing a person in charge of COVID at WVU at one point saying, at one point we had 5 pairs of booties left in the whole hospital, and that was when things were still even pretty low numbers for us. Do they getting a time to rest? Are they working 7 days a week? Are they working really long shifts? What's the hospital capacity look like? Are there still beds? Are they having to build field hospitals? I heard recently that Wisconsin's starting to build field hospitals outside of Milwaukee. That would increase this risk of psychiatric distress. And then the treatment resources available. As far as human resources, this can be, do they have psychological support services? Do they have EAP programs? Do they have other brief emotional support programs that can help them through? Are they converted medical professionals? That's another one to look out for. Are these OBs who are having to work in the emergency room? Are these plastic surgeons working on COVID units? Or are these individuals whose job it is to work in the emergency room and they're used to those procedures? Or are they people who've been kind of rerouted into that area? They talk here about residents and trainees. They talk about new teams having to form. And so if you're working really well and cohesive with your current team, but they've all diverted you to other departments, you then kind of have to build that team relationship back up. And then they talk about personal factors: sex, age, social support, coping skills, personality, whether family members have died of the disease, physical symptoms, and so on. Thoughts on this one? Okay, so this slide looks at kind of what would be the path with COVID towards suicidality for an individual. And I talk about these 3 areas under COVID-19. The first is the uncertainty, the worry and the fears about what is going to happen, how long it's going to last, what it's going to look like, how can we prevent this? All of that leads to worries. And then they talked about worrying leading to affecting sleep as a risk factor for suicide. They said that actually uncertainty is worse than just knowing there's going to be a bad outcome to an event. Okay. They then talked about social isolation. That's one that everybody kind of worried about. We know that people who are socially isolated have increased risk of psychiatric disorders and suicidal behavior in quote unquote normal times. We know about social isolation and loneliness associated with major depression and generalized anxiety disorder. And they said that this goes for both objective social isolation, actually physically living alone, and subjective social isolation, which is the feeling of being alone, even if there are people around you. And they talked about that SARS pandemic in 2003, that 1/3 of the suicide victims, people who completed suicide after the SARS outbreak, were experiencing social isolation. So that's a big one. This last one is the point that I think is really important to drive home today. And that's the economic ramifications of COVID-19 and how it relates to suicidality. So historically, in the UK, they have some kind of, and I'm not an economics person, there's something called a daily economic policy uncertainty index. And so it kind of rates how uncertain is the economy in the UK on that day. And they analyzed this over a number of years and found spikes of uncertainty. So spikes in that index of uncertainty had immediate increases to suicide rates. This wasn't like prolonged. When the uncertainty spiked, suicide rates also spiked as well. They talked about historically suicide rates increased during the Great Depression, particularly when the economic forces got really bad. So apparently in the Great Depression, there were times when economics got worse, then they got a little better and then got worse again, almost like waves, and increased rates to suicide rates kind of went in parallel with that. They also talked about the housing crisis, the economic recession of 2008 to 2010, and found that there were more than 100,000 suicides, 100,000 suicides more than was expected to have occurred during that 2-year time frame in the UK, Canada, and the US. 100,000 more suicides than normally would have been expected during the housing crisis. They also talked about this idea, let me do one more thing about, So then they talked about who are these vulnerable people. These are individuals with pre-existing psychiatric disorders that may be exacerbated by the pandemic, people who are less resilient, people who reside in high COVID-19 prevalence areas. I'm thinking New York City in March and April of 2020. And those who've had a family member or friend who died of COVID. The other group to keep in mind are people who had severe COVID symptoms, maybe were hospitalized, possibly ventilated, and survived. Because we're finding out more and more that those individuals with severe COVID symptoms have long-term issues. They're at risk for PTSD, they're at risk for depression, they're at risk for anxiety. They face a lot of long-term pain, and we know that chronic pain increases a person's risk of suicide. So that's another important area to think about. In May of 2020, a group of researchers used some very complicated statistics to estimate how many more suicides are likely to occur due to the COVID-19 pandemic. And their estimates ranged from about 2,000 to about 9,000 more suicides than expected are going to occur because of the COVID pandemic. So on this map, you go from these vulnerable people, they then talk about the mental illness that could occur, leading ultimately to suicide. Okay. So let's look at risk, and every time we look at risk, we want to also look at protective factors. Protective factors sometimes, but not always, are sometimes the opposite of risk factors, but not always. Watch my time. Okay. And so this article by Wasserman et al., this just came out, October 2020, it's hot off the press. They looked at risk and protective factors on different levels. And so they looked at it at a societal level, they then looked at it at a community level, they looked at it interpersonally, and then they looked at it individually. So there's gonna be 4 different slides that talk about different risk factors. I'm just gonna touch on a few so that we can have some time for questions. So one risk factor is the economic downturn. A former supervisor of mine actually published a study in June of 2020. It is not related to COVID because it was all conducted and written before COVID started. They submitted the study like March 13th. But they used data representative of the US population, 34,000 people from the National Epidemiologic Survey of Alcohol and Related Conditions. And they used it to look at the relationship between financial strain and suicide attempts. And they analyzed financial strain in 4 categories. They looked at financial debt, unemployment, past homelessness, and lower income. And they found that in this huge sample representative of the US, that these financial strains do have a direct link to suicide, do have a relationship with suicide attempts, and that it's cumulative, meaning that people who have all four of those financial strain factors I talked about are 20 times higher, have a 20 times higher probability of suicide attempt than an individual has 0 of those financial strain factors. And so although this came out right before COVID, other commentators have spoken out about how it can relate to our current pandemic. They discuss those implications, and they link this economic downturn that we experienced when everything shut down with COVID to the likelihood that we have higher suicide rates after the pandemic. So again, this is looking from a kind of population view as epidemiological. It's not kind of that person to person that we normally look at with psychology. But they said that it's really, they were encouraging us to pay attention to unemployment, to homelessness. They talked about increasing rates of suicide right before a person gets evicted from their home. And this is all important to talk about because those studies came out, like I said, in June, I believe it was June of 2020. So at that time, the CARES Act was there. The people had received their stimulus checks. There was a ban on evictions in the US. People were getting that extra unemployment money. Really, it seemed like the US was doing things to lower the likelihood of these financial strain factors on individuals as best they could, maybe. But what's important to keep in mind is that all ended about July 31st. So we now have August, September, October, where those safety nets have gone away for people. And it makes you wonder what the ramifications of that are going to be long-term for suicide risk. Just to touch on some protective factors at a society level, effective mental health care. So some mental health facilities closed, at least briefly. So that would have been a negative impact on that protective factor, although telemedicine skyrocketed, which would have been a protective factor. And so those may balance each other out depending on the place that the person is. And then they talk about legislation concerning the economy, like we just talked about with the CARES Act. And then at a community level, they looked at risk factors such as discrimination. There's a lot going on in this world right now, and the prioritization or not of mental health care is an important impact on suicide risk. And they talked about acculturation, dislocation. They're talking about like refugee camps here, protective factors at a community level, social integration. So they're talking about increasing resources for preventative activities, things like Headspace giving healthcare workers free mindfulness based programming for the rest of the year. Other places, I think Peloton app gave people 90 days free trial versus their 2-week normal free trial. So there were things to try to prevent some of this decrease in well-being going on as well. At the relationship level, risk and protective factors, loneliness, as we've discussed, conflicts, relationship conflict, relationship discord, relationship loss. It's spending a lot of time with people. Trauma and abuse. I know there were concerns that abuse reports are often done by schools, and when the schools shut down, might have increased the number of kids who are not getting the help they needed. And the parents interacting with the kids all the time, never being allowed to leave, never getting that energy out, might have increased the risk for trauma and abuse. But then protective factors, building strong personal relationships, connecting with friends you haven't seen for a long time over Zoom, having Zoom dates or Zoom dinners, different TV shows watching together, kind of some of the silver linings of the pandemic there. We also have risk and protective factors at the individual level. So mental disorders, hopelessness, financial problems, sleep, physical activity, food, religion. I skipped those risk factors into protective. Risk factors being mental illness, financial problems, hopelessness, harmful use of drugs and alcohol, chronic pain. But then things that could be protective, religion, food and diet, physical activity, sleep, and how COVID might have impacted those risk factors, protective factors. Looking briefly at suicide prevention, they talked about in the general population, the best thing that can happen is to decrease stress, anxiety, fears, and loneliness. Staying connected, maintaining relationships by telephone or video, getting enough sleep, healthy food and exercise, and checking in with the elderly and those living alone. I think this is going to be important to keep in mind because some of what people have done with the pandemic is started to go outside more. However, that's going to slow down with the weather. And so how are people going to readjust to keep and maintain these relationships? And then for high risk groups, those with a history of psychiatric illness, COVID survivors, the elderly, and frontline healthcare professionals, I think we have to take extra care. We need to talk to them, make our resources available, make it easy for them to obtain if it's needed. They need to keep going to treatment if they're in treatment, keep using telemedicine, and possibly increasing our contacts with people. So last bit of information before we run out of time, rural communities, suicide, and COVID. I thought it was important to kind of distill down. It's not quite a study about West Virginia, but it was Kentucky. So overall, we know that there are higher rates of suicide in rural communities. It's hypothesized this is because of low social capital, high social fragmentation, less health insurance, and increasing percentages of veterans. That is general to suicide as a whole, not suicide because of COVID. But researchers in Kentucky looked at suicide rates between March 13th and March 27th. And they found that there was actually 50% less completed suicides than in the previous 7 years. And on first glance, you're probably thinking, well, that's kind of counterintuitive. Why would we have less suicides when all of a sudden the world shut down? And so they hypothesized this was because it was called the honeymoon phase. This is when there's high community cohesion because it's the beginning of the crisis. We're all going to get through this together. Our healthcare heroes, we care about people. I think back to, I don't know if anybody watched the Disney specials that were coming out at the beginning of COVID, but even Disney was getting people together and putting on productions. They were having free concerts. You could watch Broadway shows. Hamilton came to Disney Plus. I think about that as kind of that honeymoon phase. And so they think that that was why they saw initially lower suicide rates. Unfortunately, what comes after the honeymoon phase is the disillusionment phase. This is where resources are limited. The crisis stops being an acute event and becomes a chronic event. People are discouraged, they're stressed, they're just exhausted. And this is where substance misuse may emerge. This is where people stop kind of feeling that cohesion, feeling like they can get through it because it starts to feel like it's never going to end. I worry this disillusionment phase, I think it started midsummer and I'm sure is still going on. And it's something as healthcare providers we should be aware of and looking out for individuals. And then we have a whole bunch of references for you.
Thank you so much, Dr. Lillard. That was all super awesome, and that honeymoon phase is really interesting, but thank you for that extremely timely didactic. Were there any questions or comments you all had for Dr. Lillard?
A couple things just kind of came to mind. This is Carmen. I was thinking about the economic impact that you were talking about. A group that I worry about are the business owners, especially small business owners who, you know, if their businesses don't make it through the pandemic, you know, how their resilience is going to be in terms of their own personal, you know, health and safety. Yeah, that was one of the things that came to mind.
Yeah, that's really interesting, Carmen, particularly because many people in small businesses, they put everything into that, right? They put their life savings, they're all in, and then forces outside of their control coming in to change that.
And I think for a lot of people, it's also part of their identity. I mean, it's an aspect of who they are that they created, you know, whatever that business is that's important to them.
Absolutely. Thank you for sharing. That's a good point.
Sure.
Dr. Lillard, I actually had a question. So I know you mentioned the rural study and the rates of suicidality among the rural communities. Have you seen any studies with mental health impact related to COVID among like ethnic minority groups and maybe how they're disproportionately affected by COVID?
I know I have a study here I'd have to pull out that looked at American Indians, Native Americans, and their historical trauma and how they thought that was going to actually adversely affect even more how their resiliency and how they coped with COVID. And we do know, unfortunately, that the Native American population has been very disproportionately affected. I think we have also found that minority groups, the Black community, the Hispanic community have also been disproportionately affected. I didn't come across any studies that specifically kind of tried to piece all of that apart, but I think even in West Virginia, I think Marion County saw that in the very beginning of the pandemic, and people have in the community have worked really hard to try to put more resources into testing in some of those communities to try to balance out some of the inequalities. But no, I think it's a really important thing. Let's see if I can dig anything up.
Thank you. Any other comments or questions?
So I had one more thought. This is Carmen. On a different aspect of it, this year obviously has just been been a wild ride, and we have an election coming up in a couple of weeks, and I think it'll be, you know, telling to see how people fare after the election results, whatever they are, whoever you want to vote for. If that person does not the president in January, I just wonder how some people are going to handle the disappointment and the anger that they may feel that their candidate, whoever it is, you know, is not the chosen person. So I'm wondering like how much like crisis calls and things like that are going to spike after this election cycle, because it's been tough on everybody, of course.
I agree. I actually heard a story on NPR this morning, which was looking at schools and like the financial crisis within schools, and they were talking about how many local communities just aren't talking about how much money the schools, how much debt the schools are all going into. And they were talking like primary schools, elementary, high schools. They weren't talking about universities. And they said that basically they didn't want to disrupt anything because of the election season. And so they just weren't talking about it. And that many like policy individuals are concerned of what's going to happen after this election finishes, when the reality hits that you know, either they've spent a ton of money switching to online instruction, or they've spent a ton of money making the classroom safe. And either way, they've spent a ton of money, and they don't know what they're gonna, how they're going to come out of that, especially if there's not kind of a federal level support. But Carmen, that's really interesting. And I wonder about the data, if we could look at 2016, if there were kind of shifts in distress, psychological distress after the election for people, and if that would be a good way to kind of conceptualize it.
I'm kind of also wondering, like, once the whole COVID situation is over, if it is, I keep on saying that I don't know if it's a matter of time that it's going to get over it, or whether we're just going to have to learn to adapt to live with it. But at first, my stepdaughter was really against the whole virtual learning thing, and was really upset, got very discouraged, didn't learn best that way. She really missed that social component of being at school and with her friends. Of course, you know, they missed out on like homecoming dances, prom dances, stuff like that. But when school started this year, she had registered in person, and in the first 3 weeks in Kanawha County, it went virtual. And she did it. At first, she didn't like it. But now, all of a sudden, she's kind of changed her mind a little bit, saying that she doesn't know she really wants to go to school and wear a mask all day. She's going to be limited anyway in how the classes were set up of having that social component with her friends. So she's like, I'm still not going to really get what I really want. So now she's doing the virtual and now she likes it. So I'm also curious of like, if this does get resolved, how are we going to transfer back into the school system? Because I have some kids, you know, don't like it, but some kids do like it. And I'm curious of how that's going to play out as well, of trying to get people back into the school system, or will they realize that they can offer it in both instructions? Like, will they continue to do virtual and in person and give people more options? I don't know, but yeah, it's going to be interesting. That's for sure.
Most definitely. I think even even at the college level, I've heard people talk about this. They've got this high flex thing going on where you can either be in person or you can be online, or some days you're in person, some days you're online. And kind of what I've been hearing nationwide is that students aren't showing up in person. That when you're given kind of this option in the college, many of them have shifted solely online, and it makes you wonder if there's going to be more about online education, or if they're going to just switch back.
Well, you're right. I mean, in general, to think about costs, I mean, I'm sure, you know, trying to get internet services in rural areas, you know, West Virginia would probably be a weak source in that. But in communities where states that don't have that problem, I would think in general that eventually it may be just more cost friendly, like not having to worry about having a building, keeping up maintenance. We're having school uniforms, we're worrying about school clothing, but then you get that other side of the coin where kids are not getting fed every single day, where they don't have opportunity they do get from the school. So yeah, it's a conflicting situation, but I'm curious of how it's going to play out.
Thank you. I agree.
You know, Colleen, I think it's interesting when you talked about, you know, the honeymoon phase, and it makes me wonder, you know, how much of that is, I mean, we know people who struggle with ongoing depression and suicidality, they tend to isolate already. And so that shift is not really big for them, but more with some of the individuals that socialize a lot, they had a really hard time with that adjustment. So I think that would be interesting to see, you know, how, I don't know, maybe how people with depression kind of looked at it, and really understanding, you know, if they were suicidal, you know, what were some of those factors?
Yeah, also makes you wonder about more planned attempts versus impulsive attempts. Maybe we'd see the impulsivity increasing, but not the people who are chronic.
Yeah, these are all really interesting points, and I think also the uncertainty of it all, like you were saying, Dr. Lillard, in the beginning, also affects people too. Any other comments or thoughts you'd like to share with the group?
Thank you, Colleen. I thought that was amazing.
Thanks, Amanda.
Yeah, that was awesome. And just a little side note as well, Dr. Lillard's providing this didactic at our COVID Echo as well. I believe it's November 5th. Yep, the November 5th session at our COVID Echo. So if any of you know someone who would be interested in hearing this didactic again live, feel free to email me and I'll send over the Zoom information to join that as well. So, and as always, we'll be posting these on our YouTube page, so people can watch it on their own time as well. But if there are no other comments or questions, thank you so much, Dr. Lillard. That was awesome. And I can't wait to hear it again, actually, at the COVID Echo as well. So, no, it was awesome. Thank you. But a couple housekeeping announcements. Our next session will be on November 4th. And Dr. Swagger is providing our didactic on anxiety and depression medications for pediatrics. So keep an eye out for that reminder as well. If there are any cases or questions that you'd like to submit, I always include the case link to our online form in our reminder emails and the recap emails. So that's open for all of you to submit anything that you'd like to present at an upcoming session. So we do encourage that for you all. So thank you so much, and we'll see you guys next time.
Thanks.